Morning, everyone. Welcome to the first session of the Pediatric Hematology Oncology webinar series. This first session, you can see the title in front of you today. We're going to be talking about reducing the risk of side effects from curative therapy for children with acute lymphoblastic leukemia. Thanks so much for taking the time to join us. I'm Peter Cole. I'm the Chief of Pediatric Hematology and Oncology Services for RWJ Barnabas and the Rutgers Cancer Institute in New Jersey. A few housekeeping things, just to note that everyone has been muted on entry into the webinar. This webinar is also going to be recorded. I intend to talk very fast to get through all the slides. You'll be able to catch anything that you missed by going back through the recording. If you have questions, please submit them in the chat. I may not see them live, and we may get to them at the end of the talk instead. Sorry. Controlling slides with my left hand, which is unusual for me. So these are the objectives for today. We're going to be talking about how to improve outcomes for children with acute lymphoblastic leukemia through using a precision medicine approach and coming up with an optimal individualized management plan. And we're also going to be talking about some novel targeted therapies that we're able to offer through participation in clinical trials. This session is accredited for continuing education. Physicians are eligible for one PRA, AMA Category 1 credit, and nurses are eligible for one ANCC contact hour for participation in this live activity. In order to receive credit, you have to complete the post-webinar evaluation by October 7th. So you have a while, and this information will be is available here, but will also be shared with you by email after today's session. I just wanted to say thank you to the planning committee. We had a group of physicians and allied health professionals who are planning this webinar series. I have nothing to disclose that's relevant to my presentation, other than what I mentioned before, that I'm running this lefty today because I just the other day broke my clavicle and had a concussion from a bicycle accident. That's my only disclosure, though. The content of this presentation has been peer-reviewed by the planning committee. Any controversial views that I express are my own, and I'll have references for any of the factual material that I present as we go through the presentation. All right, so that's the background. Here's the title slide. Again, we're going to be talking about using a precision medicine approach to reduce side effects from curative therapy for children with acute lymphoblastic leukemia. I also wanted to just put myself in context just by giving a very quick overview of the Pediatric Hematology and Oncology service line. We are an integrated service line for RWJ Barnabas Health with a full range of physicians providing expertise and experience in all of the cancers and benign blood conditions that affect children. We like to be an easy service line to work with. When you call us, we're happy to see patients for referrals or new diagnoses, often the same day, but certainly within a couple of days. We take a holistic approach to the care of patients and their families. We have a comprehensive psychosocial support service. We offer palliative care services. And most importantly, we provide cutting edge care to patients, to children and their families with cancer and blood disorders. We offer access to the latest therapies through participation in clinical trials sponsored by, for example, the Children's Oncology Group. We also work with the Dana-Farber Cancer Institute Leukemia Consortium. And in addition, we have access to early phase, either industry-sponsored or investigator-initiated trials. We have a very active research program developing novel therapeutic approaches through the newly funded New Jersey Center for Childhood Cancer and Blood Disorders Research at the Cancer Institute. We have a large group of physicians seeing patients primarily at 3 sites in the health system, in New Brunswick at the Cancer Institute, in Newark at the Children's Hospital in New Jersey, the Valerie Fund Center, and at Newark Beth Israel, and also at the Valerie Fund Center in Monmouth. And these are a few of our practitioners. All right, getting into the meat of today's talk, a few slides of background. Childhood cancer therapy in general, and leukemia therapy in particular, most of you know, has been one of the greatest success stories of modern medicine. In a very short period, really over the course of my lifetime, leukemia, the most common childhood cancer, has gone from a disease that was largely fatal. We're looking at survival curves. So from the time of diagnosis, what's the probability of being alive years after diagnosis? So back in the 1960s, almost everybody eventually died of their cancer. These days, children with leukemia are much more likely to be cured. Obviously, we still have some challenges, and that's what we're working on. Challenge number 1 is that not everybody, while we're optimistic, not everybody is cured, and relapsed leukemia remains one of the leading causes of cancer-related death among children, even though most will be cured. The other challenge is that when you look at the children who are cured, there is a cost to the cure, a cost on the body. And so while mostly we're excited that children are being cured, there is a cost to this, and the cost is long-term toxicity. There's a risk of chronic organ dysfunction affecting many different parts of the body that result from curative cancer therapy. I'll go through some of these. But the point is, when you look at cancer survivors, when you look at large cohorts, this is from the childhood cancer survivor cohort, more than half will have at least one chronic effect, and we're talking decades after the completion of successful therapy. So many will have more than one of those late effects I showed you on the last slide, and a third of these will be severe, including a secondary malignancy. And all of these organ dysfunctions translate into an increased risk of dying when you compare, when you compare controls who never had cancer, shown here in yellow, to childhood cancer survivors. Cancer survivors are more likely to die. And this is not only due to the risk of the cancer coming back. On the right-hand graph here, the non-recurrent, non-external causes. External causes are like getting hit by a bus. But dying from non-external causes like organ dysfunction, like heart failure caused by the cancer treatment, increases with time, even when the risk of the cancer coming back plateaus. So late effects of cancer therapy have a substantial toll on both quality and quantity of life after cancer therapy, and are an important challenge to address. So with that background, the outline for this morning, as I mentioned, I want to talk about how we like to use a precision medicine approach for children with leukemia. And precision medicine we define as using sophisticated techniques to evaluate both the cancer itself and the host, various aspects of the host, to understand how we can individualize therapy. Can we better understand interpatient variability and risk for both relapse and/or toxicity, and then use that information to individualize therapy to address both of those goals. And then in part 3, and very quickly, I'm going to talk through some of the work that I'm doing in my laboratory to develop innovative approaches for preventing toxicity when we can't come up with new therapies that are less toxic. So part 1, understanding interpatient variability. And the question here boils down to, if I'm giving all children the same therapy for the same type of cancer, some children will develop toxicity and not others. Or some children will develop worse toxicity than others. And it's not just a matter of bad luck. We want to understand what are the reasons for that variability. So when we think about any treatment-related outcome, whether it's cure or toxicity, the variability in outcome is clearly multifactorial. There are differences in treatment in the upper right, differences in the stage of disease, the extent of disease, environmental factors, which I'll come back to. For example, we've looked at variation in diet, and then patient-specific factors. And all of these have the confluence of the overlap of all of these factors determines the interpatient variability. And I'll talk through some of the variables here. So one of the factors that we think about a lot in understanding disparities in outcomes are social determinants of health. And so this is one example where we looked retrospectively at a large cohort, over 700 children who were treated in the early 2000s, from 2005 till about 2010. And we looked at those who were identified as Hispanic versus non-Hispanic. And interestingly, what we saw was the patients who identified as Hispanic on the left here had a significantly lower incidence of this one toxicity. We're looking at bone toxicity, the risk of fractures or avascular necrosis. But at the same time, they had an increased risk of treatment failure, an increased risk of the leukemia coming back. And we published this back in 2018, and others have published similar disparities in outcomes by race and ethnicity. So thinking through why that might be, we can never discount the impact of systemic racism when we're thinking about disparities in treatment outcomes, whether it's access to care, or even individual racism, implicit bias that leads to differences in how we treat patients. So we can never discount that, and we'll have to take that into account when we're thinking about disparities in outcomes. Similarly, there may be overt impact partly related to systemic racism that has an impact in social determinants of health. For example, the impact of poverty, or the difference in access to dietary factors. And we have looked, I think I'll come back to that in a later slide, I don't remember, but we've looked at changes in diet over time, and shown that dietary variation does have an impact on both toxicity and cancer outcomes. Another way to think about social determinants of health, because they relate to medical literacy, education, communication, has to do with adherence. We and many others have studied adherence. During treatment for leukemia, a big chunk, well, our chemotherapy regimens are insanely complicated. For any of you who have seen our roadmaps, the branching roadmaps within the large number of different drugs. But a big chunk of the chemotherapy that we administer is administered orally at home. And we know for a fact now that looking retrospectively, adherence has a significant impact on outcomes. Taking anything less than 90% of the prescribed dose increases the risk nearly fourfold that a child will have a relapse of their leukemia. As a parent, just when I think about trying to remember to get my kids or myself to take a full course of antibiotics, it's hard to achieve that 90% adherence, especially when you're taking a complicated chemotherapy regimen with many oral chemotherapy drugs. So we've shown that we and others have shown that non-adherence to prescribed regimens is frequent and is variably associated across different studies with health literacy, with ethnicity and race, and may have some impact on the disparity that we observe in treatment outcomes. This is something that we're looking at prospectively now in clinical trials that we're offering at the Cancer Institute, and looking at ways to improve adherence and break down some of the barriers to adherence that are coming either from the medical side or the patient and family side. Poverty is another substantial social determinant of health. We and others have, we know that 1 in 5 children in America is exposed to poverty, and this plays out with medical implications, insecurity in both in food, in access to energy and housing, leads to physiologic changes, increases in oxidative stress, increases in cortisol release. All of this can have a negative interplay with chemotherapy and alter risk for either relapse or toxicity. One of my colleagues at the Dana-Farber group published recently showing that those children who live in poverty have a substantially increased risk of relapse after diagnosis with acute lymphoblastic leukemia. This is something else that we're now prospectively tracking and looking at the physiologic and social implications of being exposed to poverty during therapy for childhood cancer. All right, besides those two, other causes of disparities that we're looking at, here's the slide. We have been looking, and we've published how diet changes independent of poverty, just going through the 2 years of treatment for childhood leukemia. I have an interest in folate, but we've looked at other micronutrients as well, like zinc, antioxidants, and showed how they relate to both toxicity and risk of relapse. And then finally, thinking about, we can't think about inter-individual differences in any outcomes without thinking about the host genome. We all differ genetically, and does our genetic makeup contribute to variation in outcomes? So the classic example of this that we think about for leukemia is an enzyme thiopurine methyltransferase, which it has been known for decades to have variants that are common in the population and that alter the activity of this enzyme. This is an enzyme that's important in the metabolism of mercaptopurine, one of the backbone drugs of therapy for childhood leukemia. And it's been known for over 2 decades now that the rare children who are homozygous for variants with low activity have substantially more hematologic toxicity during standard therapy for childhood leukemia, leading to risk of infection, risk of death, but also risk of missed doses of chemotherapy, so an increased risk of relapse as well. So this is the classic paradigm, but there are many others. So just going back to that paper that I showed you where we looked at Hispanic children treated in the early 2000s who had decreased bone toxicity and an increased risk of relapse, we asked whether the population that identified as Hispanic and the non-Hispanic population differed genetically, acknowledging that race and surely ethnicity are socially defined constructs, not genetic entities. But we found that self-identification as Hispanic does track with different prevalences of variants in genes that are listed here. These are genes that may have an impact in drug metabolism or risk of toxicity. And a few of these differed significantly in the prevalence between these two populations. Does this have an impact clinically? I wouldn't be bringing it up if the answer wasn't yes. Here's one example. I mentioned bone toxicity before. The red arrow here is showing avascular necrosis, osteonecrosis of the femoral head, which is a common complication, very painful complication among young teenagers treated for childhood leukemia. And when we looked retrospectively, we found a gene variant in this is the TS is the thymidylate synthase gene. And there is a common variant in about a fifth of children that we found substantially increases the risk in young children under the age of 10 for osteonecrosis, and in older children substantially increases twofold, increases the risk, and you can see it on the curves on the right, for breaking a bone, a fracture during therapy for childhood leukemia. So clearly it's doing something related to bone density. And other groups have shown similar associations between host genetics and risk of bone toxicity. Another example that we've looked at is chemo brain cognitive deficits, which has been one of my research interests, stimulated by my patients' complaints. When you look at cancer survivors in general, and leukemia survivors in particular, the background is that most are doing just fine. Most have a normal IQ and are doing very well. But it turns out the more carefully you look, the more you'll find that with comprehensive neurocognitive testing, survivors are more likely than untreated controls or siblings to have measurable deficits in cognitive function, deficits in attention and short-term memory. And these deficits have a real impact in that they affect school performance, later occupational performance. So cancer survivors are less likely to succeed in life, however you define success, as a result of cognitive deficits caused by their cancer therapy. And when we've looked retrospectively, we published back in 2015, there are common gene variants, polymorphisms in genes related to either neuroinflammation or defenses against oxidative stress that that affect susceptibility to this type of chemotherapy-induced cognitive impairment. So what these figures are showing is that if you look all the way on the left, just to pick one example, the nitric oxide synthase 3 gene, roughly 10% of any population will have a variant, the TT variant, that among cancer survivors, leukemia survivors, is associated with a significantly lower IQ after treatment. And the similar findings for other genes and other cognitive tests that we've done. So the bottom line is that the host genome, inter-individual differences affect our susceptibility to cancer treatment-related toxicities. So we're currently wrapping up now a prospective study where we're looking at over 500 children treated for acute lymphoblastic leukemia, and we're measuring cognitive function repeatedly during and after treatment, asking whether we can pick up chemotherapy-related changes in cognitive function very early during therapy, just like 6 to 8 weeks into treatment, before they're even symptomatic, and asking what we can learn from this. Will those early changes be associated with genetic susceptibility? Can we pick up biomarkers in blood or cerebrospinal fluid? And how does social determinants of health like poverty or household chaos interplay with all of this? How does it increase risk of treatment-related toxicity? And we'll be doing that prospectively. And over the next couple of years, we should have some readouts from this. All right, that was all just part one. Moving on to concrete things that we can do to individualize therapy to improve outcomes and address both the risk of toxicity and the risk of treatment failure or relapse. The background here is that what's interesting is if you plot, this is a somewhat old slide, but if you plot the probability of being cured against year, you'll see that the drugs that we use to be so successful are all really old. They're all developed largely before I was born, and I'm old. And so the advances in cures haven't been, until recently, driven by new drugs. It's been driven more by working cooperatively with other centers to do clinical trials, to tweak the way we administer the drugs that we use, and adapt our treatment strategies to each individual based on their risk of relapse, giving more intensive therapy to those children that we think have a higher risk of treatment failure. And most recently, we've learned that we need to intensify therapy based on response. Those children who are not having an adequate response might need more intense therapy. And I'll walk you through a few examples of this. So the objectives, what we and many others are working on, I've said this a few times now, is using a precision medicine strategy um, to increase cure rates and reduce toxicity. I won't read you all of the words on this slide because I've said most of these before. So one example is risk stratification. I mentioned that we reserve the most intense, the most toxic therapy for those children we think are at the greatest risk of subsequent relapse. Um, for almost 30 years now, we've been starting with NCI criteria. The National Cancer Institute came up with criteria based on just two parameters: age at time of diagnosis and white blood cell count, which is an indicator of disease burden. And we've stratified children into a lower and a higher risk of subsequent relapse. We've, over the last 30 years, been continually revising these criteria with the addition of additional biological information. Our most recent approach uses a refinement of the NCI criteria that includes the type of leukemia, whether it's B or T lineage. We've also most recently been piloting a modification of the age stratification. For years, we've been using 10 as our cutoff, largely because it's a round number. But we've been learning that we can perhaps push the envelope and treat children up to the age of 15 as standard risk at times. But we also use biology. We've learned in an explosion of data that what we had been calling acute lymphoblastic leukemia is in actuality close to 50 different types of leukemia driven by the genetic changes seen in each of these types of leukemia. And each confers a different prognosis, a different risk of subsequent relapse when given a constant therapy. So here, just showing one example published from the Dana-Farber Leukemia Consortium. IKZF1 is a zinc finger protein that's frequently altered or mutated within leukemia blasts. And the IKZF1 status tells a lot about prognosis. And so we use that now as a disease stratifying biological change. There are other common genetic features that drive therapy, and they have, fortunately nowadays, therapeutic implications. There are targeted therapies that have been shown to benefit children with specific changes, genetic changes within their leukemia cells. The most famous is probably the Philadelphia chromosome, which only accounts for 1 or 2% of children with acute lymphoblastic leukemia, but a tyrosine kinase inhibitor like imatinib, dasatinib, and the many others is one example of a targeted therapy that we're able to offer for those children who have this genetic change that significantly increases the chance that that child will be cured. And there are others which I show here, and along with the clinical trial that we offer participation on for access to these targeted interventions. Some newer data in the last a couple of decades has shown the importance of assessing the response to early therapy. We measure minimal residual disease. Almost all children with acute lymphoblastic leukemia will be in remission at the end of the first month of therapy. But how deep that remission is, the depth of the remission has a significant impact on outcomes we're learning. So when we measure how much disease is left, which we call minimal residual disease, we can measure it either by flow cytometry or more recently by next generation sequencing. It really separates, you can define cutoffs that separate patients into populations with a much lower or higher risk of relapse, a much worse outcome. And that's what we're showing here. We've shown this, and many other groups have shown the same thing. The important thing is that there's something that can be done with this information. It's not just something that we do to identify patients with a bad risk of relapse. We use this information. What we're showing here on the left, the data I just showed you, that patients treated in the late 1990s who had high minimal residual disease at the end, high on that study was more than 10 to the minus 3, so more than 0.1% of the cells in their bone marrow were residual leukemia. So all patients were in remission, but if it was above 0.1%, they had a dismal outcome. A protocol, a clinical trial that we ran starting in 2005, we showed that if we intensify therapy, if we give more intense chemotherapy to those children with high MRD at the end of induction, we can rescue them. And if you look, the red line here on the right are identical to those children who had high MRD on the left. And you can see that our outcomes on the right are substantially better than they were in the late 90s with intensification of therapy. So this is an important, critically important piece of information to stratifying therapy. So we act on minimal residual disease in a few ways. I just showed you that we intensify therapy. We also can bring in novel therapies. There's a bispecific antibody, blinatumomab, which engages T cells, bringing them to CD19 expressing cells like B precursor, like almost all B precursor leukemia cells. This is a drug that's now FDA approved specifically for patients who have persistence of high MRD even after intensified therapy. And this is a targeted therapy that we offer within the context of a clinical trial because of these data and the high risk of subsequent treatment failure. So pulling all this information together are these complicated tables. They're complicated on purpose because they pull together a lot of information, and they show how we take an overview of a precision medicine approach. We assign a provisional risk categorization at the time of initial diagnosis based on the clinical information that's available to us at the time, just age and white blood cell count. And then we continually adjust our assessment of the risk of relapse as more information comes in. So we start with our provisional risk group. We take biological information about the leukemia into account in assigning an initial risk group, and then stratify the intensity of therapy based on this biological information. And then as we see the response to therapy, the minimal residual disease, for example, we're able to, again, rejigger the risk group assigned into a final risk group, and we readjust the intensity of the planned chemotherapy yet again. And so this all, again, summarizes some of our research-based treatment innovations in an effort to personalize our treatment approach to decrease toxicity and decrease the risk of treatment failure using adjusting the intensity of therapy and bringing in novel targeted agents where indicated either by biology or by an inadequate response to treatment. All right. This last part I'm going to go through a little more quickly because this involves the most biochemistry, and I'm going to try to omit as much as I'm a geek and I would get excited by the biochemistry. I'm going to go quickly through some research-based approaches that we're using in my laboratory at the Cancer Institute to try to further decrease treatment-related toxicity. I'm going to show you just one example. The toxicity that I am most interested, I mentioned earlier, are cognitive deficits. They plague many cancer survivors. And to date, there haven't been any proven treatments to prevent this toxicity. We can't just omit chemotherapy that might cause this toxicity, because then patients would be at risk of relapsing and dying from their cancer. So we need new approaches for allowing the patients to be cured by chemotherapy, but preventing the toxicity that we're causing with curative chemotherapy. And so we approach this by trying to understand how it is that chemotherapy affects the brain, trying to identify pathways that we can interrupt and allow, again, allow the chemotherapy to do what it needs to kill the cancer cells, but block the off-target effects on the brain that may cause toxicity. So our approach has been to use an animal model to do this. I work mostly with rats because they're cute, also because they're very smart and they're a good model for learning about chemotherapy-related cognitive toxicity. In an animal model, we're able to study one drug at a time to really isolate the effects of each of the drugs, the many drugs that we use to cure children with cancer. And then we can study the biochemistry of how it is that chemotherapy is affecting the brain. And most importantly, we can use this model to then test different interventions that might protect against toxicity. So we've developed, I'm showing one example here with methotrexate. We've developed clinically relevant treatment protocols where we're using doses that are similar to what we use for children with leukemia. We administer them starting at a young age to mimic the effects of giving chemotherapy to children while their brains are still developing. And then at the end of this regimen of chemotherapy, we put the rats through a battery of cognitive tests that probe some of the same domains of cognitive function that are impaired among cancer survivors. We've shown that for methotrexate, just for that example, that it's a tolerable regimen. The rats, just like children with leukemia, can tolerate this regimen and continue to grow. But for weeks and months, and as much as a year after the therapy, long after the last exposure to chemotherapy, the animals show an increased risk of cognitive deficits, both in memory, in executive functions like cognitive flexibility, very similar to what we see among children. And then again, we dive into and embrace the biochemistry to look at why this is happening. And we've shown a number of changes within the brain of these animals that point to specific pathways of how it is that different chemotherapy drugs like methotrexate are affecting the brain and altering cognitive function within the rats and presumably children as well. And I mentioned already that these deficits persist and the biochemical changes persist long after exposure to chemotherapy. So it really does mimic what we're seeing in long-term cancer survivors. One thing that's been very interesting that we've learned just in the last couple of years is that in our animal model, female animals seem to be more susceptible to both the cognitive changes and the biochemical changes that we're seeing within the brain. And this tracks with what we're seeing in the clinic as well, that girls seem to be more susceptible to this particular toxicity of chemotherapy than boys. And we're probing reasons for that difference now in our animal model. So again, using this animal model, we're able to try to synthesize the data and come up with a model of how it is that chemotherapy is affecting the brain through a number of biochemical processes that are affecting, in pink here, physiology, like disrupting the blood-brain barrier, inducing neuroinflammation. All of this is mediated by many of the factors that I alluded to at the beginning, the social determinants of health, the genetic factors, to lead to variability in how neurons are functioning in either the animal brain or the human brain. And most excitingly is we're able to use this information to come up with some potential interventions. And we've had a few good hits on this already. And we've published, for example, that the drug memantine, which is an NMDA antagonist, it's one that's FDA approved. It's been in clinical trials for adults with Alzheimer's, and it's been used safely in children. We showed that when we give it concurrently with chemotherapy to rats, it is successful in reducing the toxicity. Rats who are given memantine along with chemotherapy are less likely to show cognitive deficits weeks later than rats who are given chemotherapy alone. More recently, we've been looking at the drug metformin, which is another FDA-approved, very safe drug, developed and used primarily as a glucose-lowering agent for patients with insulin-resistant diabetes. It's one that we're excited about because there are already data showing that it can be safely combined with chemotherapy for childhood leukemia with no reduction in the efficacy of chemotherapy. In animal models, a few groups have shown that metformin promotes growth of neural precursors and oligodendrocytes, and it has an anti-inflammatory impact. All of this leads to a protective effect in mice, preventing cognitive deficits induced by a couple of different chemotherapy drugs. So this is another potentially exciting intervention. I'm involved now with the NCI looking at developing a prospective clinical trial asking whether the concurrent administration of metformin among children treated for leukemia will be effective to decrease the impact of chemotherapy on cognition. There's a whole bunch of references supporting that work. Oh, good. I see a sign that says, a slide that says conclusions, so we must be coming to the end. Just to bring this all together, I've shown you that we're living in an exciting time for children with cancer in general, and leukemia in particular, where most of the children that we meet will be cured, and most will do very well. However, we're still faced with the reality that some children will die of relapse disease, so we need to do better to cure all children with cancer and leukemia. And even among those who are cured, though, there is a risk of substantial treatment-related toxicity. A precision medicine approach addresses both of these concerns, not perfectly yet, but we're making headway in using a precision medicine approach in a research context to bring in new targeted therapies and to de-intensify therapy where possible to maximize cure rates and decrease long-term toxicity. And then finally, I'm just putting in a plug for ongoing research, because research is what has gotten us to the optimistic point where we are now. Continuing research will help us be more precise in our personalization of therapy. And I've shown you a couple of examples of laboratory research, which are both bringing in new targeted therapies for leukemia, but also targeted interventions to decrease the toxicity of curative therapy. So I mentioned that all of this is collaborative work, work done not just by my lab, but in collaboration with cooperative groups, with researchers at other institutions, and much of the work that I mentioned done in my lab or that I'm involved with is funded by the NIH and the National Cancer Institute, to me at the Cancer Institute. I think I've left a little bit of time for questions. If you have any questions after this, please feel free to reach out to me by email. And before we get to the questions, I just want to also put in a plug for our next webinar session, which is going to be on December 1st, led by Archana Sharma, talking about new developments in treatment for children with sickle cell anemia. And there's a QR code that you can scan here to register for that session. Thank you so much for attending and joining. If anyone has questions, feel free to put them in the chat now, or again, please reach out by email. I'm happy to set up a time to talk by phone or answer your questions by email.